Hello, dear all. Thank you for the kind introduction. First of all, I would like to thank the organizer and Professor Chapon and Petralia for the kind invitation. It's a great pleasure for me to be here. And my task today is to speak about pain, endometriosis, and quality of life. These are my conflict of interests. So, the best way to demonstrate you the impact of the disease of women's life is to show you this cartoon designed by Professor Schweppe. I think many of you know him, but because this slide or this picture shows the impact of endometriosis very well. We have endometriosis is a chronic disease. As you can see here, it's active over many years. And beside of the pain, you know the pain symptoms, dysmenorrhea, cyclical pain, acyclical pelvic pain, painful intercourse, painful defecation and urination have a very great impact on the function of the body, and also organ damage of the organs leads often to bladder and bowel dysfunction. We saw yesterday the severe cases, severe endometriosis cases with the affected bladder and the bowel. And also infertility is a consequence of the disease, and it's not a big surprise that many of the patients have changes in the mood. There is an anxiety of the next pain, about the next pain attack, and often they have also reactive depression. But that is not only my impression of the disease, we have also scientific data about this. This qualitative descriptive study was done by Moradi, and they interviewed patients with endometriosis and asked them about their experience with the disease, and they reported about their symptoms, a delay diagnosis, which is a very big problem in the management of the disease. They reported about the treatment, about the experience with healthcare providers, and also about the lack of information. I think that is also a big challenge we have to regard, and hopefully we can improve this in the near future. So they worked out the main problems, and they concluded that there was a significant impact of the disease on the physical and psychological situation of the patients. The disease has an impact on sexual relationship. The disease has a negative impact on social life, on education and employment, was a result of also financial disadvantages in the situation. So also an effect on opportunities and lifestyle. Further on, they distinguished the groups, the group of the women into three groups and worked out the age-associated most important impairments. And it's logical that the younger women suffer from the lack of education. They were not able to do what they want. They were impaired in this situation. Later on, life opportunities and employment is difficult for the patients, and the consequence later on is then the financial disadvantages. It's logical. So what we need to do, I wanted to show you also this other study about this. Here the group compared healthy patients with the situation of endometriosis patients, and also here they were able to show significant changes in the physical functioning of the patients, in the pain level, of daily pain level, in general health, in social functioning, and also in mental health. So endometriosis has a very big impact on the life on the women's life. So what we need to do, we need to treat them, and we all do that. We do the surgeries, the excellent surgeries we saw yesterday, but in case of organ-sparing surgeries, we always let residual endometriosis, for example, in the uterus. The two cases yesterday had suffered from severe adenomyosis, so without ongoing treatment, the symptom will come back more or less. And for this, we use a hormonal treatment and the analgesic treatment. So we treated the women, but how successful is the treatment? And let's have a look at this very brilliant review done by Christian Becker's group. They worked out the efficacy of the hormonal treatment. They compared all different kinds of hormonal treatments together here and summarized the results. They looked for studies with different kinds of hormonal treatments which has no impact on the pain reduction in comparison to the placebo group, of course, but there were also patients without pain reduction. Then they looked for studies and they found out that there were also pain symptoms remaining at the end of the treatment. As you can see here, it's better than in comparison to the placebo group, but patients suffer from pain, and of course there's a recurrent pain, especially after cessation of the treatment. So recurrent symptoms after ending of the hormonal treatment because of the organ-sparing techniques, and we have to do that. We treat young patients and they need the uterus and the ovaries. They looked also for studies which and differentiate between the different kinds of pain, dysmenorrhea, pelvic pain, dyspareunia, dyschezia, and so on. And also here it's and very interesting. It's an improvement in comparison to the baseline, yes, but at the end of the treatment, part of the patients suffer from pain, and also after stopping the treatment, the pain is coming back in all the different kinds of pain. So what is the situation? I think there's a lack of information. We need valid data, how many patients are fine after surgical and hormonal treatment, how many not. I think it's a chronic disease. We need an ongoing hormonal treatment and long-term treatment. It's my personal estimation that I think a large part of the patients are fine. They can live with endometriosis, but minimum of a third of the patients are not fine. They have a complex pain situation, ongoing pains also after surgeries and under hormonal treatment. Another part of the patients are not able to use the hormonal treatment because of side effects, or they sicken also during seeking pregnancy. They can't use the hormonal treatments. So it's a difficult situation for many, many patients. And we asked also our own patients coming into our outpatient clinic, we asked for the reason of consultation, and these were patients with confirmed endometriosis, treated endometriosis, surgeries up to 10, 15 surgeries, and with or without hormonal treatment. And we asked nearly 240 patients, and the reason for them to come in our outpatient clinic was a pain. Nearly 90% of these treated patients suffer from ongoing pain. We looked for the pain profile. We distinguished between patients with and without hormonal treatment. As you can see here, both groups have comparison amount of pain, but there was a difference in the pain profile. Of course, patients without hormonal treatment suffer more from cyclical pain because they have a cycle, but they suffer also from completely acyclical pain. That is also a big problem in the pain management, and they have also other pain problems like dysuria, dysgeusia, and dyspareunia. And interestingly, the patients with hormonal treatment suffer also from cyclical pain. And that we heard that yesterday, because of the oral contraceptions, it's typical that patients with endometriosis have ongoing painful visceral bleeding during the use of oral contraceptions, and also spotting and bleeding under hormonal treatment, also under progestogens, lead to pain. And that is for the patients, is more like a type of cyclical pain. But the amount of acyclical pain is higher in these patients, and yes, it's complicated, it's difficult, and for this reason we need to know the pain mechanisms. We have to think about the pain mechanisms in more detail. And in order to understand the steps of the pain generation, it's always good to remember these 4 steps. We have the lesion, endometriotic lesions. They release pain mediators, so this biochemical signal has to be conducted into a neuronal stimulus that is due to an activation of the peripheral nerves. Then the information is going into the spinal cord. On the level of the spinal cord, there's a modulation of this input with increase or decrease of the signal. And finally, the ascent of the signal to the cerebral cortex leads to the perception of the pain, finally. And here, the lesion and the peripheral nerves means the peripheral sensitization of pain, and the spinal cord and the brain itself, that means the central sensitization of the pain. And disturbances are possible on all 4 levels. That is very important to know. So due to the disseminated distribution of the endometriotic lesions in the pelvis, we have visceral pain in case of adenomyosis, bladder, and bowel endometriosis. And in case of the peritoneal affecting, we have more somatic pain. Both pain characteristics, pain forms are completely different from the characteristics. The visceral pain is more hard to locate, it's dull and cramping, there's an emission over several dermatomes, and we have a typical vegetative reaction such as vomiting and emesis, for example. This is due because the visceral or the sensory nerve fibers use the same route than the autonomic nerve fibers, and there are interaction between both nerve fiber systems. So in case of severe dysmenorrhea, also cyclical diarrhea is often reported by the patients and explained by this interaction of both nerve fiber systems. And we have a complex interaction between all the organ systems, between the bladder, the uterus, and the bowel. The somatic pain is more sharp, it's easily located, it's also present, and in most cases we have both pain forms in the patients. So the endometriotic lesion itself, itself is an important factor for the pain generation. It looks harmless, but we know that the tissue is very active within a release of pain mediators, inflammatory mediators, growth factors. So there is an inflammation present in this tissue, a chemotaxis of immune cells, immune cell infiltrates are present in this tissue. We have a neurogenesis in this tissue with a neuroimmune modulation interaction between nerve fibers and immune cells. There's angiogenesis, lymphangiogenesis, smooth muscle metaplasia, and also fibrosis. So a lot of stuff to discuss with you, but I want to focus the situation on the pelvic inflammatory condition, the neurogenic inflammatory condition in the lesions. We know that the autonomic nervous system has a great impact in other chronic inflammatory diseases like colitis ulcerosa or whatever. And so we find here a similar situation also in endometriosis. I would like to explain this to you. We have the peritoneal lesions. They release pain mediators, nerve growth factors, so there's an outgrowth of sensory nerve fibers within the endometriotic lesion. The release of the sympathetic nerve fiber transmitters, substance P and calcitonin G-related peptide, lead to vasodilatation and chemotaxis of the immune cells. That means that is the neurogenic inflammation. But on the other hand, we have a delay or a deletion of sympathetic nerve fibers, and this might be due to the expression of semaphorenes released by the macrophages. And semaphorenes are proteins leading to nerve fiber repellent. So we have a disbalance of the sensory and sympathetic nerve fibers in this tissue, but the sympathetic neurotransmitters are more anti-inflammatory neurotransmitters, and now we have a disbalance between the pro and anti-inflammatory neurotransmitters of the nerve fibers in this tissue, and this might be a reason for the ongoing inflammation in this tissue. It's interesting that there is a high coincidence of endometriosis with other painful conditions in the pelvis. You all know the painful bladder, the painful bowel. Patients are talking about it, and we name this painful bladder syndrome or IBS. Then there is the primary dysmenorrhea, of course, because it's part of the endometriosis disease, and the pelvic floor tenderness is also present in many patients. And we think there's the pain generation is partly due to the peripheral sensitization, but also due to the central sensitization. What does it mean? Central sensitization is when a normal input, normal touch, evoked an exaggerated response. It's painful then for the patient. And this might be due to changes on the transmitter release on the level of the spinal cord here, and the modulation is changed. We have a higher facilitation and a lower inhibition of this stimulus, of this response. And this might be due to synaptic excitation, due to changes in the periphery, I don't know. Also, another pathway is also that repeated identical stimuli, like dysmenorrhea every month, lead to increasing pain. Furthermore, expanded receptive fields is also one of a pathway in this, and a crosstalk between the organs, cross-sensitization, crosstalk between the organs, and all these factors lead to the central sensitization with somatic hyperalgesia as well as visceral hyperalgesia. And there seems to be a big problem in patients with endometriosis. So for better understanding, we have here the bladder, we have the uterus, I added the uterus in this picture, the bowel efferents, we have the vulva, the myofascial structures, and all these lead to input on the sensory neurons. The nociceptors and of the peripheral tissue are activated. There's a release of the neurotransmitters on the spinal cord, and here the glutamate is upregulated, and this might be the main reason for the chronification of the pain. That is the situation, the hyperalgesia in these patients. And due to the chronic pelvic pain, and this might be independent of endometriosis, it's dependent on the pain situation. There are also altered brain morphological changes present and well investigated in many patients, and also an upregulation of the glutamate level on in the brain tissue. Very well investigated and interesting studies. So as I explained to you, we have some patients with very severe chronic situation due to the peripheral sensitization and the central sensitization. The neurogenic inflammation leads to the spinal hyperalgesia, and then there's a reflectory contraction of the muscle of the pelvic floor. And I'm very grateful for this picture modified by Pamela Stratton, because she added the pelvic floor in this concept, and that is very important. And also others, especially the pelvic pain specialist, knows for a long time that there are several changes on the pelvic floor function present in patients with pelvic pain, so we need to pay attention for this. So I think we have to add to our concept of treatment the multimodal pain treatment, and also integrative and complementary treatment strategies like manual therapies, muscle relaxing exercises. It is really easy to do that. Also, osteopathy and acupuncture have a high level of evidence to treat the pelvic floor tenderness in these patients. This is the final slide. I would like to conclude. We have the peripheral mechanisms here, the release of pain mediators, the neurogenic inflammation, activation of silent nociceptors. We have the central sensitization. We have the psychological factors. We heard yesterday about it, the endocrine factors, and it's a personal matter to pay your attention on the myofascial pain and the pelvic floor tenderness. What should we do with patients with a chronic pelvic pain? Yes, of course, we need consequent surgical and hormonal treatment and analgesic therapy, but it's also very important to give the patient the early information about the chronic disease character and its possible progression, so they need to have the chance to adapt their life, to change the lifestyle. They need professional pain management, including pain coping strategies, and so on, because when pelvic pain syndrome is already apparent, it is hard to break the cycle. This is a group. A lot of thanks to my group, and thank you for your attention.
So our next speaker is going to continue this discussion on stress and endometriosis from Brazil, our colleague, and we look forward to your talk as well. Thank you.
Thank you, dear chairpersons and dear colleagues. Thank you, my most dear friends and mentors, Felice and Charles, for the invitation. As you know, endometriosis is a chronic disease, and chronic diseases are stressful. If we take only the two cardinal symptoms of endometriosis, that are infertility and pain, you can realize that infertility is a source of psychological stress and pain is a source of physical stress. But let's think broader and think about what means infertility in a woman's life. It may also be accompanied by family demands that may be very stressful and social expectations. And pain may be, have as consequences sexual dysfunction and work absenteeism. So this is correlated by the uncertainty about the prognosis and what will come after when a woman is diagnosed with endometriosis. All of this is stressful, and there is also a high incidence of depression in women with endometriosis that is profoundly linked to the stressful life that they live. In this group of people that we studied some time ago, we could measure the level of stress in women with endometriosis compared to infertile women without endometriosis. And as you see in the right bars, both physical and psychological stress are quantitatively increased in women with endometriosis. In this study by the group from Felice Petraglia with Lucia Lazzari, they could quantify the stress intensity. And in women with endometriosis, most of them have mid or high levels of stress. This is correlated with the number of surgeries that they have been submitted to. And sometimes the stress levels may diminish, may be reduced after surgical treatment, but not always. You see that in women with only endometrioma, for example, the stress level remains the same after surgery. Stress is correlated with the level of pain. Women with most elevated levels of pain, when pain is classified as severe, have the most increased levels of stress. And it is also correlated inversely with coping. because the women with more stress are less likely to cope with the situation. So, when we do some kind of behavioral cognitive therapy, like mindfulness-based interventions that are aimed to reduce stress symptoms, you see that in this trial that we have just finished, the stress symptoms were reduced after mindfulness intervention, not in the control group. Both the stress symptoms in the past week and in the past month were significantly reduced. But what I want to show you is that when we reduce stress symptoms in women with endometriosis or infertile women as well, the depressive symptoms decrease and the quality of life increases. So it's everything linked. Which are the mechanisms behind this phenomenon? Well, stress response has been described by Hans Selye 80 years ago, and that it still stands. This is a very strong theory. We have one branch of the stress response, that is the adrenergic pathway, and this branch is related, among other hormones, to prolactin release. You see that in this rat model, we compared several types of stress, like anesthesia, surgery, hemorrhage, and the strongest type of stress for prolactin release was just the psychological stress of immobilization. So, psychological stress may be even stronger than physical stress to elicit the neuroendocrine response. This was remarkably higher in females than in males. And in clinical studies, a couple of studies have shown that there is a slight but significant increase in prolactin levels in women with endometriosis compared to controls. Another branch of the stress response is the adrenocortical axis, the pituitary, hypothalamic pituitary adrenal axis, that has been beautifully described yesterday by Professor Petralia. But you can see that in women with endometriosis, we are not sure that cortisol levels are chronically modified. There is one study using saliva cortisol measured 3 times a day that suggested that women with endometriosis might have hypocortisolism. This is kind of paradoxical. But another study shows a slight increase in cortisol levels, so it depends on where you measure it, at what time of the day you measure it, and which patient you are studying, because endometriosis is a syndrome, it's very heterogenic. So we cannot conclude whether or not cortisol levels are increased or depressed or altered in the circadian rhythm in women with endometriosis. It is probably related with the type of syndrome, the symptoms, the type of lesions, and so on. What we can see in this study just published is that cortisol levels are not correlated with the intensity of pain. There are other growth factors and neuropeptides like BDNF. BDNF has been showing in 3 studies the same results. It's increased in women with endometriosis. It is related to stage of the disease. It is related with the type of disease. In this study, we found it higher in ovarian endometrioma, which is curious, and it was directly correlated with the level of pain. Urocortins are neuropeptides that are also very related to stress, and urocortin levels in plasma are increased in women with endometriosis, are very higher compared to controls, but not so much higher compared to other syndromes with pelvic pain. So, to conclude this first part of my talk, I would say that we have plenty of clinical evidence that endometriosis provokes stress, is strongly associated with stress, and there are many mechanisms, both physical and psychological, that explain this link. But in the second part, I'd like to ask, is there true that the opposite stands? Is stress something that contributes to or provokes or aggravates endometriosis? Here there is a series of experiments in animal models because it's harder to study this in human. And in this study with swimming stress, that's a kind of physical and psychological mixed kind of stress, applied 10 days before the induction of endometriosis model, there were more lesions and with more severity in the rats that had been exposed to stress before the induction of endometriosis. When you apply stress, the same kind of swimming stress after endometriosis lesion, you also see an increasing lesion size. And this is interesting because when the rat has the opportunity to escape the stress, to escape the swimming pool and evade the stress, there is no increase in endometriosis lesion size. But when the stress is unescapable, then there is an effect that is very remarkable and the lesions grow faster. This has also been seen in the immunological system. When the endometriosis rats are exposed to stress, they have more mast cells in the endometriotic lesions compared to controls. And this has also a repercussion on the nerve system because nerve growth factor expression increases in the uterus of animals exposed to stress compared to those who were not. And what about psychological stress? Is this really impactful and important to the development of endometriosis? I'll show you some very elegant experiments performed by Professor Sanvey Gu, who is sitting here, and his group. They exposed the mouse, the female mouse with endometriosis model, to a predator outside the cage during 24 hours. The poor ones were surrounded by a cat during 24 hours. And they had been performed an endometriosis model with suture of small uterine fragments from donor mice in the peritoneal wall. As you see, those mice that were stressed with the presence of the predator had larger lesions, more cell proliferation, more macrophage infiltration, and more angiogenesis. All mechanisms that are related to the development of endometriosis. This was followed by another very elegant study published 2 years ago by the same group of Professor Gu, where they showed that the lesion growth is related to adrenergic input because when they stressed the animals before inducing endometriosis or after, or both before and after, the lesion was larger. And when they treated with propranolol, which is a beta blocker, this effect was reversed. The same was valid for microvascular density that was increased by stress and reversed by an anti-adrenergic treatment. So, to summarize the second part, endometriosis provokes stress, stress increases adrenergic output, increases cell proliferation, angiogenesis, macrophage and mast cell infiltration, which helps to perpetuate endometriosis. This is the closed cycle. So to summarize my talk, what is known? We know that women with endometriosis have increased stress prevalence and severity. We know that stress severity is correlated with pain. It's also correlated with disease extension, with coping, and with depression. This is a syndrome, a very complex psychiatric syndrome. The hypothalamic pituitary adrenal axis and the adrenal pathways are all disrupted in endometriosis. This stress, either before or after endometriosis onset, promotes disease mechanisms and accelerates lesion growth, at least in rodents. We don't know in humans, but this model is very, very clear. What is unknown? We don't know if chronic stress is a cause of endometriosis. There is no study that has proven it. We don't know if we can reduce the risk of developing endometriosis by avoiding or treating chronic stress. This perhaps may be done in some way, in some kind of cohort study or clinical trial. And we don't know if anti-stress therapies are helpful to reduce symptoms and lesions in women with endometriosis. But I believe that we have a strong background theory to support further clinical studies to try to reduce the burden of endometriosis by reducing the stress that these patients are exposed to. And this is a relaxing atmosphere, a non-stressful atmosphere of Copacabana Beach in Brazil. And you are invited to the FIGO Congress in October. Thank you.
Okay, so our next speaker is Dr. Ludwig Kiesel from Germany, and he's going to be talking to us about managing coexistence of endometriosis and uterine disorders in infertility patients.
Well, ladies and gentlemen, Sarah and Sony, thanks so much for inviting me, Felice and Charles. And I'm very grateful to you that you didn't announce the real third talk, because I'm not an expert. This will be followed later on. So I stick to my topic, which I was given by Felice, and I think he wanted to challenge me a little bit. We used to be friends for 30 years. I don't know about it from tomorrow onwards, but coexistence have been already mentioned by Michel Müller. He gave a fantastic talk about the coexistence of complex diseases in infertile patients, how you treat it, and he showed a real relevance of the subject. Now, we all know that patients who have this list of symptoms have a higher risk of endometriosis. So there may be a complex features of different types of symptoms which are not just linked to one disease, but can be linked to several diseases. And on the other hand, there could be many different coexisting features where just one of them will actually be related to the problem, such as infertility, but also others. So I think we all have to look at the patients just before doing invasive surgery, for example. So in order to answer the question about the relevance and maybe prevalence, etc., of coexistence of endometriosis and uterine dysfunction in infertile women, we did a search of the literature, and I don't want to give you the whole list of the different dysfunctions, so I just want to concentrate on the main ones we all may see in our patients. So I just picked three important features, as we mentioned, and we have seen it in the keynote lecture. And that will be fibroids, adenomyosis, and anomalies. Now, the question we'd like to answer is, what is actually the prevalence? So if you have a patient with endometriosis, how likely and how often does it occur that these patients will have something else? So a patient who you say this has endometriosis would be, let's say, red. She may be different from a different person who has two or even more diseases or dysfunctions. And these type of complex patients have been shown in the keynote lecture very elegantly. And the second part would be, is there a common cause? So could there be some kind of interrelationship between the two or even three or more features and dysfunctions? And of course, we need to understand what is the relevance for the patient. Does it really matter if we know that these are coexistent, having a similar cause or not? So looking at the literature, it's a pretty hard job to answer all these questions, and I urge you to look into these coexistent problems and maybe to design future studies, because I can assure you the data in the literature is a little scarce on many of these points. Now, if you look at the patients, let's say you're in the OR and you see the patient with endometriosis, and if you haven't really seen the patients very, in a detailed fashion, you may miss some of the features in that patient you operate, and you don't know what is hiding behind the ovary, what is in the uterus, and what's this all around, if you haven't looked in the patient's file in an accurate measure, and you would just deal with one of the diseases and missing others. So one of them, as I mentioned to you, are fibroids, as we all know, because we have the feeling there may be some coexistence because we see some of the endometriosis patients with myoma. And the question now is that coexistence which is relevant, and is that really occurring at a significant level? So before I show you the different results of the studies, I'd like to point out what are now the challenges which are related to these studies, but all of us are actually challenged if we investigate these kind of patients regarding coexisting diseases with endometriosis. So let's just start with the simple points, and these are the fibroids which can be seen on ultrasound, obviously, much better than, for example, endometriosis. So you have an investigation of ultrasound, mainly for one of the diseases, but ultrasound is not a good measure and a diagnostic feature for endometriosis. So endometriosis is more based on laparoscopy. So now, if you design a study, how are you going to handle this selection, which you may enter and may see if you select patients and you want to compare it to see the prevalence of one disease in the other? How do you look for controls? But luckily, both of the diseases can be treated by laparoscopy, and we all know that coexistence of endometriosis together with fibroids jointly adversely affect conception rates. So in infertile patients, that may be important. And also the two diseases have share common symptoms, and this is sometimes difficult to tease out which of the features are more important. And finally, this is a kind of estrogen-dependent diseases, but it's not all of it is endocrine dependent, or at least not estrogen dependent. And we heard today the talks about fibroids, and we all know that estrogen dependency is just partial. Now, looking at the studies where infertile patients have been investigated, and looking at how is the coincidence of endometriosis, and in these cases with fibroids. So one of the studies had shown that actually in these endometriosis patients, looking at 131, only 18 had fibroids alone. So we have a very high rate of joint occurrence of endometriosis and fibroids. In other studies, this has been much less, but it is all depending on your criteria of looking at the subpopulation of patients. But still, with endometriosis, the rate of fibroid was higher. And even in special diseases like this leiomyomatosis of the peritoneum in a disseminated fashion in reproductive age women, there was some components where there was an effect of smooth muscle nodules on other organs. Now, let's look at some of the other studies in a more detailed fashion. The prevalence of fibroids in endometriosis patients have been investigated to answer the question that do symptomatic endometriosis and uterine fibroids appear together. And this study by Wimari has been published in 2011. This was a retrospective study, and that's what is, unfortunately, many of the studies are actually retrospective. And they have shown that about 25% of the patients with endometriosis had also uterine fibroids, and 90% of patients with uterine fibroids had also endometriosis. So this prevalence has been obvious, and it has been shown that this is increased when compared to controls. But interesting is to see how are you going to compare patients. Now, let's look at the prevalence of endometriosis in an age-dependent manner. So if you look what is the percentage of endometriosis seen in either the fibroid group or the control group. So that's pretty different, but there is an age-dependent manner, so a decrease of endometriosis here after 45, which is different from the group if you look at patients having endometriosis or the control groups and looking what is the prevalence of fibroids. Now this is age-dependent, but mostly in different manners. So many of the results will depend on how you look at the patient groups and what are your initial thoughts and what are your initial diagnosis. Now, another important study looked at the strong association between endometriosis and symptomatic fibroids. And in this study, a very high percentage of patients, here shown at 87%, with leiomyoma having symptoms, were also diagnosed with adenomyosis and some cases with adenomyosis. Now the question is, how does these two entities relate to infertility? And obviously, we all think that the size and most likely the location of especially fibroids will relate to infertility. It may actually change uterine contractions and change the environment, having more chronic inflammation by fibroids. But many of the factors which are seen being changed in fibroids may actually be changed also with endometriosis. So there may be actually also a kind of a link. And that's not just related to these ones, but also the genetic investigations have shown that also some of the reduction of the absence of HOX-A have been shown that there is some link to fibroid and endometriosis. And just as looking at the GZ zone, as you will see in the next lecture. Now, there are also possible alterations of the steroid hormone receptors in actually both of these cases. And this is not just receptors, but also production of local steroids. So you can actually have some of the changes of local steroids, just as it has been shown for systematic and systemic. Now, our favorite field of interest to look into the detailed mechanisms are microRNAs. And we have heard yesterday a great talk summarizing all the different effects of microRNAs. And the good thing is that microRNA investigation is possible even looking in the serum of patients. So it has some advantage looking in further in the future to see if one of these microRNAs, which are related either to cell proliferation, hypoxia, apoptosis, tissue repair, extracellular matrix modeling, angiogenesis, inflammation, and some others. So these microRNAs are altered and dysregulated in endometriosis. And we are looking in different types of microRNAs to see what is their action and how they actually interfere with the development of endometriosis. Now, if you look at patients who have endometriosis and see if they also have myoma, how many of the, or which of the microRNA will be affected. And to just summarize the results, there are some, not many as you can see, some of the microRNA is also changed with fibroids. So there may be some link, but there's a lot of work to be done to see how is it with other microRNAs. And obviously, it all depends where do you take, which myoma you take, and the same as which endometriosis location you're investigating. So there'll be many questions regarding the accurate diagnosis of the initial tissue. So summarizing this part of relation of endometriosis and fibroids, so since they're both hormone dependent, I would rather say than just estrogen dependent, and both of them can be a source of pelvic pain and abnormality of menses. And the symptom severity is in both cases often poorly correlated with preoperative and postoperative finding. So we sometimes are very surprised what amount of pain some patients do have, and on the laparoscopy, it just doesn't look like it's actually that much, and vice versa. Interestingly, the size of the dominant fibroid showed an inverse association with the severity of endometriosis. So that may be an interesting aspect to look into. And there is a significant overlap of the symptoms, and it's difficult to discern to each entity. So what do we learn from this for our clinical work? So I think it needs adequate inspection, and not just looking into one entity, which we are looking for, but looking into other entities, in that case for fibroids, and especially the workup, preoperative workup will be important, especially in infertile patients. Now, looking at the other disease, which is adenomyosis, and it obviously, as shown in the keynote lecture, there's some relationship potentially between endometriosis and adenomyosis. And even in this case, there may be some adenomyosis in that patient. Now, this is an organ not taken from that patient, but it just demonstrates you that you can actually have that kind of finding, which is coexisting with endometriosis. Now, looking at the studies, it has been shown in pathological samples from hysterectomies for benign and malignant conditions that there is a definite increase of adenomyosis in endometriosis patients. And it's more difficult to say what's the exact number for infertile women. Some studies have a lower number than others, and some of them have actually a certain correlation with certain stages of the disease. And also there are differences in the junctional zone depending whether you have endometriosis or if you have less. So it's actually an interrelationship between the two diseases quite obvious, and even the thickness may correlate to some extent, as shown by Brosens. So one of the studies looking into that feature is doing a laparoscopy and finding the endometriosis group, and afterwards looking at the MRI and seeing that in the endometriosis cases you have thicker junctional zone, and that's demonstrating a higher prevalence of adenomyosis. And also looking at in another study by Leindecker, looking at the prevalence of endometriosis adenomyosis, which was very high in that study, especially in that with that thickness, and looking at the prevalence of adenomyosis in endometriosis, you can see that it's also quite high. So the question is, where is the location of this adenomyosis? And that can be obviously at different places, and that has been studied in that publication. Now, is there a pathological link between, and pathogenic link between the two diseases? And Leindecker has published, and I'll just recall this paper, demonstrating one of the potential mechanisms with an injury being the cause for both endometriosis lesions as well as endometriotic lesions. And if you are more interested in that link, you can look that up. There's a lot of details about the different steps, how that might occur. Now, the hypotheses of the different diseases, adenomyosis and endometriosis, whether this has a common pathogenesis, is dependent on the idea that maybe endometrial stroma is involved in invagination, and that has been published first by Frenzy and later by several others, but also the mechanical damage which can occur, which have maybe the cause for both diseases, as well as the dislocation of basal endometrium for both entities. And there are an increasing number of publications where there are increased expression of the same factors in both diseases. So there may be some kind of link between the two diseases. Oh, thanks. So I will jump. I thought I have the fourth took too as well. So the antimullerian diseases are complex matter, and I'll make it a bit shorter. So septate uterus seems to be an interesting point because there are more associated cases with endometriosis than in controls. In other studies, it has been only shown that obstructive uterine anomalies will be actually important, but not if you just generally compare with and without Müllerian anomalies. So if we summarize, I've shown you that there is some increase of these three entities with endometriosis, and there is some indication in the literature of these other two features like anovulation and PCO. And also, as you know, there may be some increase of the risk of cancer with endometriosis. So there's a whole range of different interaction and coexistence with endometriosis. So if you want to figure that out, you need to do studies, but it's very difficult to find the right controls because it depends which group you're investigating in order to get that finding. And it may be if you investigate the other group, just as I've shown you for fibroids and endometriosis, you end up having different percentages. And even more difficult is, of course, the causal relationship, and this has been not well demonstrated and no good RCTs. And one main reason is that, especially in clinic, you think things are similar, but basically they may have different pathogenesis, so they just look a bit similar. And that's, I think, is important. And finally, we all have to find out what's the relevance. Is it coexistent with major relevance, or it's not just coexistence, it's also just coincidence. So we need to find out which is the case in which patient. Thanks very much.